Stand by. Okay. We are live in 5, 4, 3, 2, 1.
Hello, everyone. I'm Dr. Georges Benjamin. I'm chair of the Committee for the Analysis to Enhance the Effectiveness of the Federal Quarantine Station Network based on lessons from the COVID-19 pandemic. I have a public statement that I need to read before all of our public sessions. So I want to welcome everyone to this open session of the committee's first meeting. I want to note that this is an open, on the record, information gathering session. That is, the committee is in the process of assembling materials that will examine and discuss in the course of making its findings, conclusions, and recommendations. Therefore, I ask everyone here today to be mindful of the fact that the committee has made no conclusions and that it would be a mistake for anyone to leave here today thinking otherwise. Comments made by individuals, including members of this committee, should not be interpreted as positions of the committee or of the academies. Now, this is the second meeting of approximately 4 to 5 planned full committee meetings. And some of these meetings may include public sessions that we will have the opportunity to hear from experts in the field. The committee will deliberate thoroughly before writing its draft report. And moreover, once that draft report is written, it must go through a rigorous review by experts who are anonymous to the committee. And the committee must then respond to this review with appropriate revisions that adequately satisfy the Academy's Report Review Committee and the chair of the National Research Council before it is considered an NRC report. Now, the expected report releases around May of 2022, and further information on the study may include future meetings can be found on the project's website. Now, this open session today provides an opportunity for the committee to discuss with CDC leadership and others, and in this case, the former principal deputy director of the CDC, what obstacles the Division of Global Migration and Quarantine face, and where the committee could investigate how to help remove them. During the Q&A session and discussion, the committee questions and comments will take priority. The public can submit comments to the study email address listed on the project website. This meeting is being recorded. It's now my pleasure to introduce Dr. Ann Shugart, the former Principal Deputy Director of the U.S. Center of Disease Control and Prevention. Ann, welcome.
Thanks so much, Georges. And I just wanted to make a few comments before we have a discussion. First, I want to thank the Academy and the committee members for what is an incredibly important and timely mission. I know between the individuals on this committee, you have thousands of person year and emergency year experience and have probably faced many of the challenges that you're hearing about from the different presenters. And I do think CDC and the nations are going to benefit from your committee deliberation. This is a really complicated issue. And so I'm glad to know there's going to be repeated meetings and discussions and some time to digest. I think that there are more opportunities right now than there are challenges, that the horrors of the COVID pandemic, the loss of life and the impact on migration and movements is so extensive that there's more appetite for change and for investment than we probably ever had. So I hope your deliberations can come up with really strategic and actionable advice. In terms of the complexity with the members, this, but the many different federal entities that share this space with the CDC, while we have the quarantine authorities, the interdependence with many other federal entities, and the interplay with local and state government is very important. The interplay with the private sector is substantial. I don't think I appreciated how substantial it was until I was in the midst of the pandemic with the team in the division. And then the expertise involved, but the level of policy deliberations were often disconnected, extremely technically expert, legally expert individuals working day in and day out in this space, and then periodic need for high level decisions, approvals, direction that wasn't always in sync with the technical work. The public expectations, I think in our time of pandemic, we can't underestimate. I think there's a part of our nation that assumed we had the kind of quarantine capacity that you see in parts of Asia where nobody can get off an airplane without being put into a government hotel for 2 weeks, undergo rapid test and be have an ankle bracelet on, I think. But we obviously don't have that kind of capacity. But I think we need now to think through what kind of capacity we really should have and how to get there, how to be able to be nimble and surge and scale because the pathogens can't wait, and how to not just have emergency resources that come in months after they're needed, not have policy deliberations that take 20 years, which you've probably already heard about, to get the contact information to be shareable in electronic ways, how to deal with our privacy concerns and our freedoms, as well as the public health needs. There's a lot of pressure and responsibility that's been put on our Division of Global Migration and Quarantine and also on CDC. And I think having a clear understanding of scope, scale, terms, and independence would be really helpful. So I imagine you're thinking about legal issues and technology and people and money and governance. And I think all of those are going to be important in the future. I welcome the questions that you have and need to say that of all the things that were difficult during the period when I was still at CDC working on the pandemic, the issues of our quarantine capacity authority and pivots, I would say were at that highest level of challenge. So again, thank you for what you're doing, and I welcome the chance to talk with you.
All right. Questions? And, while waiting for someone to, Bradley, let you go first.
Okay, thanks. Dr. Choquette, thank you so much for being with us today, and thank you for your leadership on this, particularly in the early days of this pandemic. You mentioned that the interdependencies and the authorities with the quarantine regs. So in my experience, when I was at DHS, this was a big issue of trying to, oftentimes CDC would have the authority to do something, it seemed like, but without the capacity to implement the authorities. And so I was wondering, could you kind of expand on your thoughts around that, around the interagency dependencies and the authorities?
Yeah, and I know you've spoken with Marty Satron and some of the division staff, so you've got a probably visceral feel for this challenging area. But when a decision is made about what the quarantine order will be, the ability to implement that is dependent on so many other partners. Even if CDC had unlimited dollars and people, so much of this is in, Department of State, Department of Transportation, Homeland Security, CBP, airport personnel or border personnel. And, the logistics are unbelievable. So I was really impressed with the interagency partnership. I don't even know what they call the group, all those different acronyms working together on figuring out, how we were going to take that next step. But what I think was difficult with the pandemic was the need to take that next step right away and not have, pileups of thousands of people in a tiny airport space. The design of airports, in fact, was a barrier to accomplishing many of the needs. I would look with envy at the TV reports of these big hangars where people in Taiwan were waiting for their lab test results when we just really didn't have that set up. And that private sector issue I mentioned was, there wasn't a big appetite to interrupt the private sector, to have fewer people coming through the airports. And so, you could have a plan for an order and an inability to implement it, or not a chance to roll it out. So I think we need to come up with practices that are realistic and space that's realistic, and decisions that are, a better syncing of the decision with the ability to roll it out. And I think there was great goodwill between the technical groups across the interagency space, and there was often not enough time to make things happen. There was also the issue of how do you do the notifications, because so much was proprietary. There were decisions and then you couldn't talk about them until they were announced, but you had to be able to plan to implement them. So I think for almost every order I recall, there was this very difficult day, 2, 3, 4 days of the thing's been announced and there's total chaos before it's a smooth operation. And that, I think we should be able to do better than that in the future. That's just a small number of the things I recall that would explain what you were asking.
Thank you.
Michelle, Stephen, and then Moon.
Hi, Ann. I'm actually in transit, so recognizing all the difficulty in travel. I have a question for you. Marty Group covers a lot. It covers, as you know, can you hear me?
Yeah.
Are you able to hear me? It
Yeah, it's going
covers,
in and out a little bit,
migration, traveler. It
You might want to turn off your video,
many
Michelle.
things. Okay, sorry. Can you hear me now?
Yeah, that's
Much
better.
better.
Can you hear me, Ann?
Yeah.
Okay, so Marty's division covers many things. It covers, migration, refugees, it covers travel, it covers the Texas-Mexico border. Do you think that if we split things apart and had just one section doing quarantine and the panoply of things that involve quarantine, do you think that would be better?
I think it's worth thinking about. Clearly, the scope of what the division works on is incredible, and the expertise involved in any one of those areas was just substantial. It was really impressive to see the team at work, explaining to FAA what the pilots ought to do when they're overnighting in Alaska, and then dealing with the ICE concerns about crowds in facilities at the border. I think that the trick is in what's separable, what is so interdependent that it needs to be together. Any one of those issues that they deals with many other agencies, and there is value, I think, in the relationships that have been developed with the different groups across the interagency space. But it is a huge scope, and I think we thought about some of the things. They were very expert in community, in essentially non-pharmaceutical interventions in the mitigation issues that were really theoretical until this pandemic, where we implemented all the social distancing. Is that expertise around modeling and movements something that could be pulled out because it doesn't have the regulatory responsibilities? But the maritime issues, it isn't just quarantine, it's the movement that became, what we, even without orders, that became very demanding during this pandemic, funneling airplanes and being able to track whether there were quarantine orders or not. So that's a clear, think about it, but I don't have a strong view one way or the other. I do think, though, we have to staff and support this set of activities, whether they're in multiple units or together, and that the thinking, basically over supporting it. We can't expect to surge at the speed that we need with temporary people who have no idea what they need to do. We need to over invest in this area for when we need it, because I think we've really gone the opposite way of underinvesting and closing down quarantine sites and having a too slim a team that then has to surge. And they've had to surge for since 2009, pretty much continuously. There hasn't really been a big break in the emergencies. There's just been 2 or 3 at a time instead of only 1 at some points.
Yeah, that's why we're a little bit worried about burnout as well.
Yeah, and I think, you have to think of what are the factors that go into burnout. Part of it is, I mean, I saw it literally 24/7, that the kind of experts that we had. I mean, these group, they are really phenomenal. I'm sure it's come across, but it's not just working hard and working long hours, which theoretically you can improve with better staffing and shifts and really, required vacations and so forth. But I think it's also the nature of the work, the heartbreaking aspect of a lot of what the field staff does, or the really the heartbreaking circumstances that individuals are in those refugee context or at the border. So I think there was some emotionally challenging work as well as physically challenging work.
Stephen.
Thanks, Ann.
Sorry, my cell phone is ringing. Let me shut it off. And it's great to see you. I'm sure you're greatly missed at CDC, and I hope you're getting some much needed rest. You mentioned a couple of things, and a couple of things have also come up in our deliberations up to this point. And one of them, you talked about independence as an issue. Another thing we've discussed is that there were some fairly creative uses of quarantine authorities over the past year and a half or so. In particular, we've sort of discussed the eviction moratorium, and then the issues related to the southern border and using the quarantine authorities to reduce movement of people across the border. And you also sort of talked about this disconnect between the expertise at the within the division and at the technical level and the policy decision-making process. And I guess my question is it practicable to think that there would be full independence in terms of how these authorities are used? And would you anticipate that there would be this type of expansion in terms of the way that the quarantine authorities are implemented going forward? And is it appropriate to do so?
I think we went into this pandemic with certain authorities that CDC possessed that were handy for a lot of purposes. I think just taking the eviction issue, I think clearly, being evicted in the midst of a pandemic is not a good thing. Figuring out, what authorities are needed that may not exist is probably important going forward. There were, there I guess always are going to be policies that people want to implement, and some sort of matching process to find the authorities that fit. But to preserve and protect those that have a public health purpose, to assure that they have support from the public and the policymakers long term, that they're not abused, that they're used sparingly, I think is going to be important. But I think we can see out of this pandemic that there are probably some authorities that they're not, that need to be either new authorities or clarity around authorities that exist. It doesn't seem like a great use of resources in the midst of a pandemic to have this many lawsuits going on. I feel like we needed surging in public health staff, and what there was so many times where our technical experts were really busy, supporting some of the legal defenses rather than necessarily whatever was necessary at a local or state level. So I think there's, that issue's important. I'm not speaking about any particular use of the authorities, and I'm not an expert on them. There were some that I got involved in as they came up, but I think this disconnect, though, just a couple comments on that. CDC's always got suffers from some disconnect from the policymakers in Washington because of the geographic distance. The number of departments and agencies involved in some of the issues that the division works on, and the level of involvement, you know, assistant secretary or higher level, can put our agency at something of a disadvantage. You know, it didn't necessarily, I mean, I thought the groups really did work well across, but you know, we didn't necessarily have enough, maybe enough presence in DC virtually, or enough leadership involvement to help with some of the tricky negotiations. You know, so it may be that rather than just expanding the staffing at that front line, we also need to expand the leadership level engagement in this work, because it is pretty complex, and you know, you can't put it all on one or two people to navigate it. I mean, you know, I don't know how Marty's still alive after all he had to do this past 2 years. So.
Moon.
Hi, Anne. Thanks so much for your time today. I was wondering, looking back, are there activities or some of the things that the quarantine stations were doing with international passengers in the beginning, pre-diagnostics, that you would have liked to see them doing? And then what kinds of activities do you think weren't as effective, both sort of in the pre-laboratory diagnostic phase, and then once we had diagnostics available, are there things that you think were less effective, and would have you liked to see other things being done during that time? Thanks so much.
Yeah, I mean, I'll probably just cover this at a very high level. You know, I think for a pathogen that is most infectious pre-symptomatic, we had, you know, a daunting task. Obviously, we're not going to have we did not have, and we're not in a position to have enormous numbers of accurate rapid tests available in the first weeks or months, really, of this pandemic, let alone even, you know, actually even now. But we weren't you know, if containment was going to require detection pre-symptomatic, our quarantine approach wasn't going to detect infected individuals. On the other hand, the ability to identify and follow travelers from at-risk locations or from flights that potentially had active infection, passengers who were actively infected, you know, that kind of capacity would have been possible had we gotten buy-in to electronically share traveler information, you know, accurate traveler contact information. And the amount of person time, you know, and laptop purchase and you know, effort that CDC and CBP and, you know, the airlines and so forth had to do, because nobody in the government, I guess, was willing to require the airlines to share electronic manifests. I can't believe that was a barrier as long as it was. I don't actually even know if it's been fixed yet, but, you know, that was something we've been talking about for many, many years, pre-Ebola and post-Ebola, and it still wasn't available. So, you know, it just meant that the state and local public health was set up to fail before they even started. You know, we just you know, you're always going to need to develop a new test if it's a new pathogen, and, you know, you're going to need a government or venture capital investment to scale that test rapidly for availability where you need it. But the idea that you can't even know who was on that flight using the technology that's available is kind of ridiculous. And then also the ability to not have to have a labor intensive way that you track individuals, but to be able to automatically say, hey, you were on a flight with some people who've been diagnosed. Here's what you need to do. Here's where you can go get a test. Here's what we want you to do in terms of staying home before or if you get symptoms. You know, the things that other countries were able to do, we just didn't have political will, I guess, to go for. I'm not sure if I answered your question, but I answered somebody's question on that. So,
No, that was helpful. Letha, and then Marcy.
Yeah, well, thank you, Anne, for raising the issue of mental health and burnout. I think that's super important. And I would like to know if, are there any actions in place to prevent burnout or to respond to burnout in these circumstances? Because I think this can be a major issue with staff retention, a major reason why staff is leaving the division. So are there any, I don't know, activities, programs for mental health in place? Or have you think about that?
Yeah, I'll just mention a little bit that I'm aware of. There may be more, but I know that the division was very sensitive to this issue earlier than maybe the whole agency was. We did have a resilience a program that the Emergency Operations Center pretty much led, pre-deployment, post-deployment, and then for those functioning within what became a virtual Emergency Operations Center, some efforts to try to help people have connectedness and decompress. But Marty's division took on a more intensive voluntary program for essentially emotional support, processing of the challenges that people were going through. And I know they were doing it before the pandemic, I believe, and then it became something, or maybe they started it during the pandemic, but it became something that would be, that they had to pay for and so forth. The agency paid for, but at a pilot way that then got offered to the agency more broadly. I don't know what state and local health departments were able to do or what some of the other agencies were doing, but I know that it was a big issue for CDC. Our trainees, our epidemic intelligence service officers were often deployed without the same kind of training that the quarantine officers have. And so I think there was a lot of, this has been tough on people at every level, whatever was going on with you and your family. But I do think the multiple deployments to the border in particular were very, very, really challenging. And part of it is what you saw, and part of it was the limited control that anybody felt, about what they could, whether they were being deployed for a purpose that they were trained in implementing, or whether they were, not able to use the skills they had in a really, just overwhelmingly difficult circumstance.
Marcy.
Hi, and it's good to see you as well. Always enjoy hearing your perspectives. I'm going to follow up a little bit on Moon's question, as well as it's an issue I keep raising both on this committee and in various other roles that I'm on, but it's trying to sort of look at when does it make sense to put in place such an active monitoring program. First time it was really done was for Ebola. I remember when I was on the first call with Marty, when he announced that we were doing this prior to Ebola, it was much more focused, or maybe just focused on an individual flight or a particular passenger. So for Ebola, it was a gigantic effort that was stood up. We monitored people for 21 days, obviously didn't detect any new cases that way. And, I always thought for Ebola, given the way Ebola is transmitted, ideally, we wouldn't have just focused on travelers from 3 large countries, but focused on people with true epi risk. And then on the other extreme, there's COVID, where I realized in the beginning we didn't know. So this is more sort of going forward. But, once it was established how transmissible this was, how much pre-symptomatic, asymptomatic transmission, every time we've stood this up, especially once it became more established in the US, it sort of focused efforts away from known cases and contacts to people who may or may not have had COVID, but were from an area that was listed as a concerning area, like was recently done with the countries from Africa. So the question is, going forward, what your thoughts are for when it makes sense to stand something like this up, like what are the characteristics of an organism where it makes sense, or where ideally we wouldn't consider this, political pressure aside. I don't know if that was clear.
Yeah, I mean, I don't have an easy answer. I think the issue, one of the concerns that I have is whether you call it the mental model that we have or the dogma that we have. But I think those of us who worked in respiratory viruses and influenza, really didn't believe you could contain a respiratory virus that is spread relatively easily. But I mean, it's amazing what a number of countries were able to do with pretty strict border measures, and with aggressive contact tracing and snuffing out the spreading events, in the early days, like looking at Singapore, looking at New Zealand, looking at, South Korea. And so I kind of sometimes feel like we gave up too quickly. Not that we gave up, but some localities really were aggressive and some were less so. But I don't think at the beginning of an emerging infection that is crossing borders, we're going to know all that we want to know about the circumstances. And so I think for us, a little bit of what was feasible had to lead rather than what was ideal. And I think your committee has this window to say, well, let's forget about what's feasible today. What would be feasible tomorrow with investment and systems buildup? What's worth it versus what is just a waste of energy. We were spending a lot of time early on trying to move from having to have people quarantined, to doing everything in transit, to really getting people. We were trying to get the policy in place so that people would quarantine when they reached their final destination rather than, en route. But we didn't really get a shared vision of what's, and I guess jurisdiction to jurisdiction, it varied of what is quarantining at home, self-quarantine or self-monitoring. We didn't push that at the national level. And I think state and local varied on how much they pushed it and, how quickly they gave up and what was the public, appetite. But I do think that we've had so many points in this pandemic where if we had been able to get a shared agreement to be more aggressive, we would have had less challenge, if we were all on the same page with it. And so, you can look back and think, when we thought it was so bad, it really wasn't so bad. It was going to get so much worse. And hopefully this winter won't be that way again. But I do think the initial weeks are so important, really important. So I'd love it if you guys could recommend a design, even if it's building out the airports, getting plans that would incorporate lab testing, would incorporate the technologies and the automation of what makes sense for the travelers versus the heavy lift that the state and local or CBP or CDC had to do.
Yeah, if I could just do a quick follow-up. I totally agree about the countries that were able to use it successfully, but most of them, I think, were islands, and it was easier to do, and they didn't have all the different jurisdictional issues that we have in the United States. But I think the bigger issue for us, I know, was once we actually had cases here, to focus those same efforts on travelers who may or may not have had COVID while we were actually trying to do the same for known cases and contacts. So that was part of the challenge. But
yeah, well, I think we didn't have enough resources for all the things that were important or priority setting. But, I think there were things short of regulatory orders that we could have been much better about. I just think of all the international students coming home, where it was pretty much chaos what they were supposed to do. We didn't have a policy machine that could say, have them stay home for, 2 weeks when they get there. Don't mix with the other students or with the town. Because of our local, state, federal governance issues, there wasn't an appetite at particular levels for that. And then the universities were kind of on their own and often we're doing, I think, good things, but not letting, the scientific experts or the government provide, support for that. It was fairly, it was pretty chaotic, as many will recall. And that was way before, anybody was not letting the travelers come. But, the European travel was the big thing here since China, stopped their own travel really before we stopped theirs. And I think seeing those outbreaks, we just, I think we had it's not going to happen here. When I say we, it's like the big we. It's not any one individual or agency.
Susan, this is Georges. You think that we could, could we all get in a room and at least put together some boilerplate scenarios with guidance that if we could get everybody to agree to them, that would be useful enough to give us a few weeks of order while we figured this kind of stuff out?
I think there's a lot of merit in that. I think, as some people know, there were a lot of drills and scenarios and so forth in the different zones of pandemic, response. But the leadership in place at the time of this emergence wasn't really following those drills. So, not to say that the drills were all on point, but there had, now that we have had this set of experiences and we have different tools than were available 20 years ago, what I do think what you suggest would be useful, but you have to do the connect with the political level, which changes. It can be great when the long-term local, state, federal public health folks are in agreement, and the long-term, transportation, DHS, state are, and but there have been a lot of, I remember like taking over the airplane drills that in some of the airports were like really vivid exercises, but now I think we have a set of scenarios that were broader than what we were planning before. So yeah, I think that's a good idea. I don't think I wouldn't assume that it's all going to be followed, but I think you'll figure out what some of the additional barriers are going to be, and if there's an appetite to fix them, where there's authorities or legal concerns, to understand how far we can go.
Thank you. Stephen.
Yeah, thanks. Sorry to ask another question before others, but one of the things that has come up in the discussions is that we really didn't have plans in terms of where to house people if we needed to actually place them in quarantine or isolation. And so there was some default to using military facilities. And I guess the question is, do you have any thoughts about what potential alternatives may be needed? Obviously, other countries have sort of taken over and had quarantine hotels and things like that, or made people pay for their own quarantine. But any thoughts about how to solve that?
Yeah, we can't go in, we need to do better. This was definitely a problem. I think we had not, in our planning, there was a containment phase and then there was another phase. And by the time, the thought of large scale quarantine wasn't something that was prepared, that we planned on. Some of this jurisdictions planned on local or state quarantine, and part of their state plans had to be like, yeah, we have a plan here, where we're going to put people, but the federal level hadn't invested. And again, this is one of those ones where, if there's money and it's not just for emergencies, it's doable. So I think the issue with the irony was, none of the hotels wanted people, but then they lost all their business. So, your quarantine people could have been your best business. The same thing with the eviction thing, okay, now there's federal money to help people stay in housing, or to help those who don't have housing get housing. The apartment buildings that are, used for that, it may be the only rent they can get. So I think we should be spending more on this just to have it ready. I think this is clearly the pandemic of COVID is costing more in livelihoods and lives than the US was expecting. And we should be putting huge amounts of money to better manage this in the future, this kind of thing in the future. So, I don't know whether they're hotels or some other facilities, but I think we can't, just the amount of person time that went into the negotiations with the bases and the interagency, who's doing what, where it was, I'm sure you're aware, there were just a lot of gaps in who thought they were doing different aspects of what was happening for the federally quarantine. And I think you'll hear, or you have already heard from the state and locals about their plans on larger scale quarantine or larger scale support, just the isolation that's needed for, pulling a person out of their home where they could be infecting others, but to safely support them. It costs a lot, but I think we need to do that. I mean, I just think it's the right thing to do to have safe places for people to either isolate or quarantine, and to not penalize people for being infected, really. So
Let me ask a quick question.
I'm sorry, go ahead. Yeah.
No, go ahead, Ann.
I was just going to say, especially when you look at the disproportionate toll of serious illness and death in lower income and people of color, we're just not, the idea that you can isolate and protect your loved ones in the way that many people live is just, it's just not feasible without, I think, government support.
Moon and then Marcy. And then I have a question.
Okay, thanks, Ann. I was wondering about the cruise ships, and at the beginning they were a big issue. Now there are some local agreements in place. I believe that those might be altered in the future, but in the beginning, are there other regulations or issues with working directly with the cruise lines when something like this happens in the beginning weeks, like you were saying, that need to be in place so that shiploads of people are not left stranded prior to porting? I know that was happening a lot and just out at sea, unable to anchor. What are your thoughts on that? Thanks so much.
Yeah, I have to say, at many of the topics that are coming up, I have fuzzy memories of the probably healthy responses to trauma. But I would say that here's an area where I think independence and decision-making could be helpful. There was a period where, CDC does have a no sail authority, an ability to say, you can't, that ship or that group can't sail for health reasons. And there was a period where it was fairly clear that it was not wise for more people to board cruise ships. And yet the case for that and the recommendation for that occurred, and there was a delay before that order could actually be implemented. It could be agreed upon at higher levels. And I think that the most important stuff is probably going to have the biggest economic hit. And you cannot, any of you who were state, local, or federal at that period will remember just enormous amounts of effort dealing with crew, passengers, loved ones, constituents of every congressman who were stuck on a ship someplace, or potentially quite ill, and not the toll that took versus the work that all those entities should have been doing to prepare for the larger wave that was essentially already coming or here. We could have turned that tap off basically earlier and focused effort in ways that were more impactful, knowing that of course you needed to care for and help resolve those. But it was months of crews stuck in very difficult negotiations at the ports. I'm looking if anybody's from California. It was pretty tough in California with a number of active issues out there that were being dealt with really at the same time that Santa Clara had community transmission, and people were worrying about whether people could board or not the next ship, which they were allowed to, unbelievably. So yeah, I think I'm just giving an emotional response, not a very concrete response, but I do think that we could do better. But again, just remembering that there's a lot of, there's appetite when it doesn't cost anything to the private sector. And when the private sector is going to lose, it becomes a policy matter at a higher level, and CDC wasn't high enough up I think, to take some of the actions that we wanted to.
Marcy.
Sure. I was just going to go back to the comment about quarantine capacity. In New York City, when I was there, because I left last week, this was such an issue for us for over 20 years. Like, we had been working on it since around when we started working on smallpox and bioterrorism preparedness. And the challenge is always finding facilities that exist that have all the things you need, the ability to feed people, care for them, clean their rooms, laundry, et cetera, ahead of time, that are willing to do this. And then literally within days of, the city shutdown, every hotel in New York City volunteered to open up their, it was a way for them to survive during most of the shutdown. And I totally agree with you. I was so amazed at the ability to get people out of small New York City apartments to be either protect them from their ill family members at home or vice versa. It was amazing. But then the city opened up again and the hotels wanted to get everyone out and get back to being able to charge a lot more. We actually moved, it was in the news a lot, we moved our entire homeless shelter population into hotels, and we had very few cases. And then unfortunately they all moved back, and now we're seeing that go up again. So it's just acknowledging that, yes, ideally we would have a place. Like, I remember being in Beijing with you, Anne, a long time ago, and watching how quickly the Chinese were able to get up massive quarantine facilities. But it is just so hard in between to either find places that are willing to do it, that exist in the event of an emergency, or like keeping places ready to go in the absence. So it's just the reality. I think it's always going to be hard. I'm hoping we can leverage what happened to get the hotel industry to agree to do this next time ahead of time, so we can quickly move to it. But it's just such a challenging situation to have turnkey facilities ready to open up and staff them.
Yeah.
Question, it was more a comment.
And obviously a lot got done. But as we all know, a lot got put to the side. Can you talk a little bit about what got delayed, or how the juggling occurred? Because obviously that's a big issue. Lots of stuff happened at the state and local level that just didn't get done. And we're now having to play catch up. What happened to CDC?
Yeah, I mean, the last numbers I saw were, more than 9,000 CDC staff had been engaged in the response. And those are people who have day jobs. There's not too many groups other than Marty's that, this is essentially their core mission. And that core mission also included, not just COVID, but Afghanistan and measles and DRC and, on and on. So I think it's going to take some time to see all the things we didn't do, in terms of the TB cases that weren't followed and that, began chains of transmission. Obviously, the childhood immunization coverage dropped quite a bit, and the mental health worsenings, the opioid epidemic getting so much worse. So while we, on paper, continued the essential efforts, they were not, the state and local partners we depend on were not able to do all that they usually do. So I think, probably in every area, there were gaps. Just think about how important, colonoscopies and mammography are to preventing colon and breast cancer and or to early detection. And all of the elective procedures that were canceled, delayed, or, people didn't feel comfortable leaving their homes. So, and, again, right now in Michigan and other places, there, the surgeries and hospitalizations for other factors are really impacted by the surge in COVID that they're having. So I think almost everything that public health does probably got worse, perhaps less eating out in restaurants that might have been spreading outbreaks, but a whole lot more people, isolated and having the challenges of disrupted schedules. So I don't have the laundry list, but there's a laundry list there. You could just go center by center, but the data are already out on the opioid epidemic and childhood vaccines for sure.
But certainly substantial. Ed,
And I was wondering if you could just comment on non-emergency authorities, and if you can think of any areas where you would say, oh, we'd love to have that authority for the public health purposes. And what I mean by that question is, obviously we're in the midst of a pandemic and we're in a national public health emergency, and that activates specific authorities or not. But the vast majority of what DGMQ has had to do over the last 40 or 50 years has been below that level. And it's either dealing with the individual TB patient or the refugees from Afghanistan or the Tex-Mex border, et cetera. There's the southern border, or cruise ships. And I guess the question is, for those, what I'll call, for lack of a better term, day-to-day crises and day-to-day emergencies, that's the bread and butter of what DGMQ does. Did you and Marty ever sit over a beer and say, we really wish we had this authority or that authority that would allow us to actually impact these crises that we're dealing with on a daily basis, as opposed to when the world is having a problem, if that makes sense to you?
Sitting with Marty over a beer sounds like a great plan right now. But I think that one gap, I'm not sure if it's in authority or it's in support for the authority, but it was pretty, there's an area, and he could share in more detail. There's this area where the federal, the CDC, not the federal government, but the CDC within the federal government is essentially the payer of last resort for some of these issues. If we quarantine a person with TB or whatever, that's not something that insurance is going to pay for. We end up having to pay that toll, and that just seemed crazy that this was a part of our health system, that you would take a tiny little division with hardly any money that was always having to cut costs and put individual patient care costs on top of their work. There also there were some of these, non-emergency but day-to-day crises around the drugs that we don't have, where it's not really an authority, but essentially the ability for compassionate use to use, the malarial drug that China made that we didn't have here. That was a big lift for DGMQ to get the product to be deployable within a certain number of hours. And there was, it's not really authority, but it's regulatory, I guess, that, that people had to be under an IND protocol. And it was just we couldn't get the product in all these hospitals because you would need an individual IND at the hospitals, which wasn't so practical. And so the quarantine stations held essentially held the IND. And anyway, I'm not describing this very well, but it was a bureaucratic problem that didn't seem to be contributing to any patient safety. And yet the burden was on this little division to overcome that. So, I guess if you mention authorities, we always come back to, direct hiring authority and payment, and, all the FEMA authorities, CDC could benefit from, in terms of how to spend money quickly in an urgent situation, rather than the complex contracting that we need to do, how to get people on board quickly, which I guess we might have gotten some of that for the emergency context anyway. So it's not well thought of, but I think others would have a good list of authorities.
And I guess the question I would have for you on that, not being an expert on FEMA. So FEMA, and we can, in closed session, we can go over this, but your understanding is FEMA has the ability to do direct hires and to allocate funding in a way distinct from yours so that they can respond to crises in a distinct way?
Yeah, they have these task orders that they do. The direct hiring is some of the other agencies, not necessarily just FEMA, but when they go for an earthquake or hurricane, they can spend money. It's not so simple for us. We have to get the money to this. We have to get the money to the states, which usually means the states have to apply for money. I mean, it was amazing how much money was moved quickly during this, but it didn't necessarily get to the towns. It got to the state, and then it had to get to the county, and then it had to get to the NGO. So I think FEMA can just spend a lot of money quickly, for good reason. Not, they get audited and everything. everything. And they are very aware of the fraud that occurs in all these emergencies. But their procurements are much more simpler. So I believe they have simpler procurement authority than we do, even in emergencies.
Yeah, it's true that their authority is quite different. And we talked about that. We talked about the fact that a lot of the health authorities, a lot of the health problems that happen with health emergencies are not reimbursable under FEMA. That's the other issue, which at some point someone really needs to look at. Stephen.
You're muted.
I'm sorry. One of the things you didn't bring up in your opening comments that I think is a big issue is around communications. And it's kind of one thing to institute or initiate policy decisions or use certain authorities and not be in a position to really be able to effectively communicate why those things are being done or why those things aren't being done. And I realize that there were a lot of constraints around that, but I mean, in terms of the fact that this is an area where CDC is regulatory and the agency isn't in general a regulatory agency, I'm wondering what your thoughts are around the best way to deal with communications in the area of the authorities that this division has.
Yeah, I mean, it's extremely complex in the pandemic where, the authorities are being used in the middle of a whole lot of other stuff that's being done and who ought to be communicating in what way. Clearly there's been a shift from the last administration to this administration on how the communication is working, with CDC doing a lot more communication. But the regulatory side, I think that's a good question that needs a bit of thought. Some of these issues were such that CDC was the entity being sued, but was not necessarily the voice explaining the why or the how or the what. In general, I would say if a action is being taken for public health reasons, the public health voice would be important. So often the communication was local or state here because the situation was so different in different jurisdictions. But for cruises or for eviction, I guess for those policy matters, a CDC voice would have potentially made sense. The aspect of, there were decisions made about, it's going to be a press release, not a press conference. They were such bureaucratic sounding orders, these things when they happen, or our order would be a part of a package that was a federal, an executive order with three, with a quarantine order and two State Department, communiques or something. So I don't have a good answer on that because it was usually not an isolated CDC action. Certainly when we added in, you have to get a lab test to come back. It was a mix of orders and other policy decisions. Same with the masking in the federal transport corridor. I think Dr. Walensky's done a really nice job of, putting the public health voice out there for what action CDC is taking or helping explain, the bigger picture. So I do in general think it's good for CDC to be vocal about the context and the framing. But I don't have a simple answer to that question. But I agree it was a problem.
Other questions? I think.
I'm so glad you're looking at this. This is such a powerhouse committee with really good perspective. So, we do need, I think the nation needs us to have an improvement plan and hopefully help us get there.
Okay. Well, Jason, and then I think he's going to be our last question. Jason.
I have a comment. I just want to thank Dr. Shuchet for your comments. And I want to share one little experience. But when we look at Taiwan's response, in fact, that's what they did. Is they took the response from the typhoons, from the earthquakes, which they have quite often, and they made the regulatory authorities to be comparable to response to hurricanes, typhoons, and earthquakes in a pandemic response. And that's how they amended their Communicable Disease Control Act, including the digital cellular responses to the public. So.
Fantastic.
Sounds like a model, right?
All right. Well, listen, Anne, let me thank you very, very much. That was quite helpful. And I we all really appreciate you being here. We also, by the way, appreciate all your many years of service to the nation. Quite frankly, we're all safer because you were there at CDC. So again, let me just publicly thank you for that.
Well, thanks, everybody, and appreciate all the work you're doing and will be doing. So a pleasure talking with you guys today.
With that, I think that brings the end of our open session. We're going to now leave this open session. We're going to take a break. I'm going to ask everybody to come back here in 10 minutes. So if we make that, let's make that 2:15. Does that work? All right, everyone.
Yeah.
Thank you.
Okay, we are off stream.